All right, so welcome to our fourth seminar of the Disability Health Research Seminar Series. We are really honored and fortunate to have the opportunity to speak with Dr. Scott Landis today, who is Professor of Sociology and Faculty Associate at the Aging Studies Institute at Syracuse University. My name is Franz Castro. I am a Research Associate at the Johns Hopkins Disability Health Research Center. My visual description is I'm a Latino man with black hair in my 30s, wearing a black suit, sitting in an office in Baltimore. My pronouns are he, him, and I am so thrilled for this discussion today and for you all joining us. So I first want to mention that we have card captioning services available. The link is going to be added to the chat. We also have ASL interpreters joining us. Thank you to the interpreters and the captioners. So today, Dr. Landis will be talking about a very timely topic, which is understanding of disability as a demographic. As for logistics, after the presentation, there will be a Q&A session with you all in the audience. Please feel free to place your questions into the Q&A function. Your messages will be sent to the speaker and to the moderator, and then we will read them out loud on your behalf. And please remember that we have ASL and closed captioning card services, which are provided through the Zoom platform or through the link in the chat. For your awareness, this session is being recorded. If you have any technical difficulties during the session, particularly in terms of access needs, please contact Mindy at epits4@jhmi.edu. Next slide. So we would like to begin today with a land acknowledgement. We recognize the enduring presence of more than 7,000 indigenous peoples in Baltimore City, including the Istakawe, Lumbee, and Eastern Band of Cherokee community members. Next slide. For those joining us for the first time, this series is linked to a course that is being run out of the Johns Hopkins Bloomberg School of Public Health in partnership with the Disability Health Research Center, directed by Dr. Bonnie Swinner. If you want to learn more about our work, you can do so by going to our website, disabilityhealth.jhu.edu. Check out our podcast included and our social media accounts. We will be posting about this session as well, the next sessions in this series on all of those channels. So next slide. And with that, I will introduce our speaker today, Dr. Landis. Dr. Scott Landis is an associate professor of sociology and faculty associate in the Aging Studies Institute at Syracuse University. He received a Ph.D. in sociology from the University of Florida in 2014, informed by his interest in medical sociology, aging, and the life course and disability theory. Most of his research focuses on health and mortality trends across the life course for disabled people and disability measurement. It is a privilege to be welcoming Dr. Landis today. Thank you so much for taking time to join us. We are extremely grateful that you're here today. And without further ado, I'm pleased to introduce our speaker for today, Dr. Scott Landis.
Thank you, Dr. Castro, and thank you to Johns Hopkins and the Disability Health Research Center for this invitation. So my name is Scott Landis. I'm a white, middle-aged male with short brown hair, a brown and white beard, gray-rimmed glasses with a purple opaque right lens, and today I've got on an aqua dress shirt, gray sweater vest, and brown corduroy jacket. My pronouns are he, him. And pertinent to my identity, as well as my topic for today, I'm multiply disabled, both visually impaired and immunocompromised for all of my 53 years. I will not be using slides today as I myself struggle to see them, and I tend to get lost when I try these days. And as I start, I want to recognize two colleagues with whom I have collaborated in work on this topic and have been formative in some of the ideas I'm presenting today. Dr. Bonnie Sonor at Johns Hopkins, and Dr. Jean Hall at the University of Kansas. My topic for today, as Dr. Castro said, is disability as demographic. Now, the larger context that frame my ideas are the measurement of disability in US population surveys. And so those surveys that we use to better understand socioeconomic and the health status of the US population and subpopulations important for today, such as disabled people. And I have three underlying assumptions that I make when I think about measures such as demographic characteristics within population surveys. My three assumptions are: number one, that all measures of demographic characteristics should be accurate, meaning they measure what they're intended to measure; inclusive, meaning that when used, they count as many people with the characteristic as possible; and number three, that they're equitable. And for me, that means that they are created, at least for the disability measures, in robust conversation with the disability community. But at best, they would be created in efforts led by disabled individuals and in robust conversation with the disability community. Now, I think it's important that we understand that when we engage in measuring a phenomenon like disability, we're wading into the process of classification. And I want to address this briefly, as this process has some very obvious upsides, but also some unavoidable downsides that I think we don't discuss enough. When we classify people, as we do with survey measures such as demographics, we're categorizing them. And whether we classify or categorize, and for this talk, I'll use these terms interchangeably, we're engaging in a process of de-individualization. So if we're honest, although we're concerned to accurately, inclusively, and equitably measure demographics such as disability, to a certain degree, we do so not to fully understand each disabled person's experience with disability, but to group each individual into a broad category that can be used for analysis and to inform policy. And in doing so, I think it's important to admit that much is lost. Furthermore, those things that are lost in this process are very important things about life and experience. And so I think as I get started, we should pause and discuss the downside first of classification and measurement front and center, because disabled people in the US, as well as beyond, have for way too long been on the losing side of classification and measurement. And this is an element of the discussion on measuring disability that I personally think that non-disabled people are either not aware, or if they are aware, do not give sufficient consideration. We in the disabled community have been, and often still are, classified and measured in many, many ways across our lives that de-individualize, marginalize, and harm us. And to step back a bit, it's not only us in the disabled community that have this experience. It's been a common experience for many minority communities, as we see in Zuberi and Bonilla Silva's classic book on white logic and white methods, that racial ethnic minorities, gender minorities, sexual minorities have been classified and harmed through measurement for many years. And we in the disabled community have been part of that experience as well. Bowker and colleagues, and Bowker, B-O-W-K-E-R, point out that classification and measurement are ethical choices, as they're decisions about who is in and who is out. And this is most noticeable in severe cases when classifying people leads to very obvious harm. And the first thoughts that come to mind for me regarding disability in the US is the classifications that surround the institutionalization and forced sterilization of members of our community. And while instances of severe harm still occur due to classification and measurement of disabled people, many of us are also worn down day by day by less severe but incessant marginalization and measurement activities that we experience day in, day out. And so for this reason, many disabled people, and I think we really need to acknowledge this, including myself, have very visceral reactions to this process, especially when it's pursued in a way that excludes us. Now, flip side. As a researcher, I'm convinced that despite the inherent downside of classification and measurement, it can be done in a more equitable way that provides benefit to the disabled community. Specifically, if done well, measuring disability can improve our understanding of the socioeconomic and health patterns in our population, such as levels of education, employment rates, experiences with healthcare access and barriers, health status, mortality risk, which is what I primarily study. And all of these, plus the many more pieces of information we get from these national surveys, prove useful in trying to understand both the level of integration and success that the disability community experiences, as well as inequities, marginalization within our community. So it's a trade-off, but it's one we need to more readily admit. Yes, we de-individualize, but we do so in order to gain a better understanding of our population. And the important point is that these efforts to classify and measure have to be equitable. So let's turn our attention to the way disability has most recently been measured in US population surveys. The set of questions that were set as the standard for measuring disability in the US by the Department of Health and Human Services are commonly referred to as the ACS 6 questions, and ACS being short for American Community Survey questions, where they were fielded starting in 2008. So two of our primary population surveys in the US, the National Health and Interview Survey, which I'll refer to as the NHIS, and the American Community Survey, both started using the ACS 6 questions to measure disability in 2008. However, and this is part of the larger context of why we're even talking about this today, the NHIS switched from using the ACS 6 questions to the Washington Group questions in 2018. And this was the same thing that the US Census Bureau stated they intended to do in the 2005 American Community Survey. Now, fortunately, as many of you know, after receiving overwhelming feedback from the disabled community and allies, the Census Bureau paused this change. And as of what we know right now, plans on continuing to use the ACS 6 questions in 2025, but we're not yet sure what they will do past this point. So in our search for more equitable disability measures, I want to address a concern that is present in both sets of these questions. So I don't want to just single out one or the other. I want to critique both the American Community Survey 6 questions, the ACS 6, and the Washington Group questions. So Gene Hall and colleagues at the University of Kansas reported in a Health Affairs article, I think it was last year they put this out, that among a group of disabled respondents from the National Survey on Health and Disability, now everybody in this survey has reported being disabled. And so among these respondents, the ACS 6 questions failed to identify 20% of these disabled people as disabled, and the Washington Group questions failed to identify 43% of these disabled people as disabled. So although the ACS 6 outperformed the Washington Group questions, neither one did well. Both the ACS 6 questions and Washington Group questions undercounted or artificially reduced the size of the disabled population. And so our question has to be, what's going on? Why is this the case? What is it about these questions that are resulting in not providing an accurate count of the disabled population and not including all disabled people? Is there something about the questions that prevents them from being inclusive? And I think there are two actually aspects that we need to address. The first, and the one I won't spend as much time on, is that both the ACS 6 and Washington Group questions are premised on conceptualizing disability as a functional limitation. In fact, you'll find some proponents of these questions, especially those in favor of changing to using the Washington Group questions, who will argue that they are not even trying to measure disability per se, but they're trying to measure functional disability. Now, this is a very, very important distinction. The basic idea behind this is that disability is solely defined by functional limitations, meaning a person has difficulty completing a core set of specific tasks: hearing, seeing, cognition, mobility, self-care, independent activities of daily living, or communication limitations in the Washington Group questions. Operationalizing disability based on this definition means people who have difficulty with at least one of these functions are counted as disabled. but people who do not are counted as not disabled. So bear with me just for a minute. Let's suspend our judgment on whether disability should be defined based on the presence of functional limitations. And so in a second, we'll interrogate whether this assumption is worthwhile or not. But assuming that functional limitations are the best way to describe and define disability, as is done in the ACS 6 and the Washington Group questions, one reason these sets of questions don't count all disabled people is likely due to the limited number of functional limitations they include. This fact's been documented by disability scholars and advocates for years. If we wanted, if we wanted to continue using functional limitation questions to measure disability in the short term, we would need to add additional questions that include functional limitations associated with intellectual and developmental disability, physical health disability, mental health disability, and communication disability, specifically for the ACS 6. Many disabled people with these specific conditions have functional limitations, but in ways that are not captured by the limited list of functional limitation questions included in the ACS 6 and Washington Group. If, and I'll get to the reason why I keep emphasizing if we accept measuring disability as functional limitation, the types of functional limitations included in these questions must be expanded in order to make these questions more accurate, inclusive, and equitable in measuring the disabled population. Now, here is the if. I think there's a much broader problem at play here, and this is where I want to spend the rest of the talk. And this really rose to the surface during the recent debate regarding the Census Bureau's plans to change the disability questions in the American Community Survey. Many disabled people, including myself, do experience functional limitations. However, there are disabled people who do not experience functional limitations. And so let me repeat this idea, but do it a little more pointedly. Measuring disability as a functional limitation will never be accurate, inclusive, or equitable because not all disabled people experience functional limitations. So let me give you 3 examples that illustrate this point. And these are not exhaustive, but they help to illustrate the point and get you thinking about who doesn't have functional limitations within the disability population. The first example is disabled individuals who have some type of bodily disfigurement, disabilities that are not commonly associated with a functional limitation. Now, to be clear, bodily disfigurement can, for some people, be associated with a functional limitation to mobility or hearing or vision or something, but it's not the case for many people with this disability. Though not commonly experiencing a functional limitation from this condition, individuals with bodily disfigurement are disabled according to federal policies and laws such as the Americans with Disabilities Act amendments of 2008. And frequently, these disabled individuals, especially if their disfigurement is apparent to others, experience discrimination, marginalization, and ableism due to their disability. Yet when we measure disability as a functional limitation, disabled people who do not experience functional limitations are not counted as disabled. This is ableist logic, and these are ableist measures. So second example, disabled individuals who have functional limitations, but they're episodic. Sometimes this can be referred to as dynamic disabilities. It can be the case with some mental health disabilities and physical health autoimmune disabilities, such as arthritis, multiple sclerosis, Meniere's disease. Individuals with these conditions often have episodic functional limitations, meaning they have times in which their disability directly causes difficulty with hearing or mobility or cognition. However, many people with these disabilities experience periods of what we would quote unquote call remission. Sometimes short duration, sometimes long duration, in which their disability is not associated with any functional limitation or is associated with less severe limitations. However, this is really important. During these times of remission, and I can testify to this as someone who's immunocompromised, you're required to strategize and manage social interactions and expenditures of energy, spoons, healthcare treatments, stress, and many other factors in order to attempt to reduce the frequency, duration, and intensity of future flare-ups that you know are coming. And you often continue to experience disability-related discrimination and marginalization, even during the times when you're quote unquote in remission. And so recognizing the severe challenges that management of these episodic conditions present, the ADAAA recognizes, and I'll quote here, that an impairment that is episodic or in remission is a disability if it would substantially limit a major life activity when active. Yet when measuring disability as a functional limitation, disabled people whose disabilities are episodic are not currently experiencing a functional limitation are not counted as disabled. Again, ableist logic, ableist measures. So third example is disabled individuals who have functional limitations, but they're effectively mitigated by medical, therapeutic, device interventions, supports, or accommodations. And this includes individuals with episodic conditions, such as those I just mentioned, as well as the many other disabilities that are associated with permanent functional limitations. For people with these disabilities, the degree to which a person experiences limitations related to seeing or hearing or mobility can be the result of whether the built environment is accessible, the access the disabled person has to resources and accommodations, such as screen readers, ASL interpreters, mobility devices, and whether others in the environment are willing to accommodate them, which we all know that despite the advances of the ADA is a big if. A disabled individual who uses a cane and lives and works in a fully accessible built environment may report they don't have any functional limitations with mobility, whereas that same individual in an environment that is totally inaccessible would report they do. Both are disabled. Yet when we measure disability as a functional limitation, disabled people who do not experience functional limitations due to interventions, devices, support, and accommodations are not counted as disabled. Again, ableist logic, ableist measures. So as I'm hoping you'll get with me, these examples illustrate that basing the measurement of disability on functional limitation leads to the exclusion of many disabled people, particularly those who do not experience functional limitations at all, experience episodic limitations, or because of the accessibility of their environment, don't experience functional limitations. All of these individuals are disabled according to federal policies. All of these individuals experience marginalization and ableism, yet they're not counted as such when measuring disability as a functional limitation. What these examples underscore to me is that defining and measuring disability as functional limitation does not provide an accurate count of this population, is not inclusive, and is not equitable. So the big question, are there alternative solutions that would be more accurate, more inclusive, and more equitable? And I think there are, and the one that I want to describe today is conceptualizing and measuring disability as demographic. Now, demographics are key characteristics of individuals that are used to help identify and group or classify members of the population. So again, we're still doing classification. They usually include characteristics such as age, sex, gender, and race ethnicity. So like I talked about earlier, we are classifying, categorizing. There's an upside and downside. But what I'm arguing for is conceptualizing and measuring disability as a demographic characteristic. Now, this is not a new idea as far as the articulation of disability as demographic. Healthy People 2020 report by the Department of Health and Human Services and HHS and their 2011 guidance on measuring disability both stated that disability is the demographic characteristic. But there's a really important caveat here. Although they said that disability is the demographic, and that's gained some traction among disability researchers and public health researchers, within those standards, and most often within research, disability as a demographic is pursued in tandem with the argument that disability should be measured with functional limitations. Now, this is a methodological mismatch. You can't do these two together. So let me be clear on this. Demographic measures should measure all people with the described characteristic. We would not accept measures of age that only count some people who are age 53 as 53 and simply leave out the other 53-year-olds who aren't counted. Or we would not accept a measure of Hispanic or Latino identity that arbitrarily excluded some Hispanic and Latino identifying individuals from being counted as such. We expect our measures of demographic characteristics to accurately measure people who have that characteristic. The same should be the case for disability. For this reason, functional limitation questions cannot be used to measure disability as demographic. They're not acceptable for the purpose they're intended. So it begs the question, what concept should we be using to define disability if we don't use functional limitation? How should it be conceptualized? Now, there's a ton of work that needs to be done in this area. For me, a great place to start is with the work of Elizabeth Barnes, who's a philosopher at the University of Virginia, wrote a really good book called The Minority Body. And Barnes contends that disability indicates a minority pathologized body that is inherently different from society's normative standards of what it should be. And I don't agree with all of Barnes' arguments on how to define disability, specifically her choice to exclude cognitive disability from her definition and the seeming passivity of the disabled body in her thought. But despite these disagreements, I think she's onto something and offers us a great place to start thinking about ways to define disability other than via functional limitation. Because within this conception, a disabled person with functional limitations would be considered disabled as they have a minority pathologized non-normative body mind. But so would a disabled person who does not have functional limitations, such as the examples I gave earlier of people with bodily disfigurement, dynamic disabilities, or whose functional limitations are mitigated with supports. In both cases, the disabled person, with or without functional limitations, still would be considered to have a minority pathologized non-normative body mind. So I want to note, if we move down this road, which I think we should, we're moving away from relying solely on the social model, which I think is a good thing. As we all know, the social model states that whether we're disabled or not is based wholly on social structure or environment. And while I don't deny, especially as a sociologist, the role of the social structure in our disability experiences, and the social model really has helped to advance our rights in important ways, as many scholars have contended. In making this claim, the social model really abandoned our bodies and left them to be defined by the medical community. And this is my contention. Measuring disability as a functional limitation is a direct result of the social model logic that separates disability from impairment, which to me is a false separation, and in doing so mistakenly cedes our bodies, what they call the impairment in the social model, our bodies and our minds, it cedes them to the medical rehabilitation classification systems. And this is readily apparent if you read Nagi's original work, or if you read Verbrugge and Jett's work on the disablement process. Both of these types of models promote the problematic strategy of conceptualizing and measuring disability as a functional limitation. Defining us by whether we have functional limitations is a very limited medical rehabilitation perspective that fails to recognize that many disabled people don't, but are still disabled and are marginalized for being so. So in contrast, if we shift to conceptualizing and measuring disability as minority bodies that are pathologized and different from society's normative standards, that moves us into the territory that allows for classification based on both body-mind characteristics and the social experiences and meanings of these normative standards. Now, in case you're thinking, no, this is unadvised, it's not appropriate to consider both bodily characteristics and social experiences to measure demographics, I just have you consider we already do this. This is how we measure gender and race ethnicity. Now, I would hesitate to propose or think that any conceptualization and measurement of disability will ever be 100% accurate, inclusive, or equitable. But I am convinced that moving away from conceptualizing disability as functional limitation towards conceptualizing disability as a minority body mind will lead to more accuracy, inclusiveness, and equity than we have in the ACS 6 or Washington group questions. So now what do we do as far as operationalization? What types of questions should we be asking to measure disability as minority, pathologized, non-normative body minds that may or may not be associated with functional limitations? And this is a place where I will only make some suggestions with the very clear caveat that these are the ideas of one disabled man. To achieve a greater level of equity, it will be imperative for those creating new disability measures to do so in consultation with the disability community. And as I said earlier in the talk, preferably with leadership by disabled individuals. And as is the case with any new demographic questions, there would need to be appropriate cognitive testing and field testing to determine the performance of these questions. It's a process that will take time, but it must be pursued if we're to achieve more equitable measurement. And this is where I've most closely collaborated with Dr. Swinor and Dr. Hall. I think we need to ask a multi-pronged question that ensures we count as many disabled people, excuse me, with and without functional limitations, whether they identified as disabled or not. So although it needs to be part of the equation, we can't simply ask, are you disabled? Because not all disabled people have a disability identity. We can't simply ask, do you use special equipment or devices? Because not all disabled people do. Instead, we need to include as many of these descriptors as possible. Something to the effect of, do you have a disability, impairment, physical or mental health condition, chronic condition, aging-related physical or mental impairment, or military service-connected disability? My guess is there are many other terms people use to describe their disability that I'm missing here, but I think you get my intent. We need to use as many of these as possible to ensure inclusivity. This could then be followed with questions regarding specificity about the particular disability, impairment, or condition, whether it is or is not associated with functional limitations, whether it requires the use of special equipment or devices, whether it requires accommodations to complete daily activities, as well as duration of disability or impairment. And so please note here, I'm not throwing out measures of functional limitation. I'm arguing that we should quit pretending that these questions measure disability, but instead use them for what they do measure, whether a disabled person does or does not experience functional limitations. I'm going to end here and loop back to the beginning of my talk. By doing so, I want to emphasize that the process of measuring demographics, such as disability, what we call classification systems, these are ethical choices regarding who is in and who is out. Classification systems are typically generated by those in power, which in the US, as well as abroad, has most often, if not always, been non-disabled people. This must change as we move forward. We need new disability measures that are more accurate, inclusive, and equitable. I think the best way forward would be measuring disability as demographic. But no matter what direction we take, any efforts to advance the measurement of disability must robustly engage the US disability community, be highly transparent, and ideally should be led by disabled people. It is past time that we've moved beyond ableist logic and ableist measures. We need disability justice now. Thank you all.
Thank you so much for this great talk, Dr. Landis. This conversation was a great reminder of, as you articulated, the need to envision more equitable and inclusive ways of measuring disability and the importance of understanding disability as a demographic to better understand socioeconomic factors which are ultimately impacting health and participation of people with disabilities in society. So with that, I want to open it up for audience Q&A session in the last 20 minutes. We have a couple of questions here to start out. There's a question that says, thinking about ableism at an even higher level, do you have any comments on the pros and cons of thinking about disability as opposed to variations of the human experience?
This is a great question, and it's something that I don't know that I've processed all the way through, because there's been I think a necessary movement among racial ethnic minority communities and race ethnicity scholars to really emphasize over the past 10 years that it's not race, it's racism. because for so long, where they're talking about social determinants or fundamental cause theory, the assumption has been, well, race is related to higher rates of morbidity or higher rates of mortality. And so we need to change things so that people, of minority race groups have access to resources, better healthcare. And what scholars have said, no, this is missing the point altogether. It's not racial differences, it's racism. That's what's killing us. That's what's causing the difficulty. And I think your question gets to that. And I mean, in the talk I just gave, I'm going along the line of along the lines of disability, the demographic characteristic. And I think that's important here because, and I will readily admit, as a disabled person, our bodies are involved in this process. I mean, there are things that our bodies are doing that at times can lead to more difficult health experiences. And for some of us, our disabilities are directly related to health conditions. Not always, but sometimes. But I think it's really important that we try to make a shift to say it's not just disability, and it may be not primarily disability, but it is largely ableism that is killing us. I've got a study that I'm working on right now showing that disabled people across the board, age, sex, race, ethnicity, socioeconomic status, are about 2 times more likely to die than their non-disabled peers. And when I was working through this with the editors, they were saying, well, how much of this is disability and how much of this is something else? And I think there's something else that we need to be articulating is how much of this is the ableism that we experience, that we're not allowed in, that we're not allowed the resources that we need, that the stresses of just trying to deal with this from day to day. So yeah, great question. I think the real issue is, to parse this out, we've got to to me, the baseline, and that's why I started here, we've got to have better measures of disability. We're going to also need some measures of structural ableism so that we can tease out how both are in play.
Thank you for your great answer. I really do appreciate the perspective of including or taking into account the role of ableism into this discussion in relation to the question. So moving on, there was a comment in the chat from a listener who was wondering how to honor each person's unique experience of disability while also generating useful data about disparities and inequities that disabled people experience.
Yeah, I think that's a great question. We've got to respect how people self-identify or don't. And this is going to take, I think, a lot of field testing. And this is why also I think the federal agencies that are developing these questions or looking at developing these questions really need to have robust interaction with the disability community. I mean, as we know, there are many people who have conditions or impairments that some folks would say this is a disability, but they won't call themselves disabled. They would just not the term they use, or they're actually against doing so. And they'll say, I have an impairment, I have a limitation. I personally think we have to respect that. That's how people identify and describe themselves. That's really their decision. But the questions that we ask, if we're trying to get to this larger concept of kind of this minoritized, pathologized, non-normative body-mind, is going to have to be inclusive of all those terms that people use. And so to me, that's the front end of testing that would need to be done is how are people describing a common experience? So if you have 30 people who are visually impaired, we need to be talking to them and say, how do you describe yourself? Are you calling yourself visually impaired or visually disabled? Or you're saying I have an eye condition or whatever it might be. And to see if we can come up with questions that really respond to the way people are self-defining. We've done this with race ethnicity. Census and interagency committees have done this. Pew Charitable Foundation did testing on this to try to determine whether the questions that are being used to measure race ethnicity actually pick up on how people describe themselves. We've not done this with disability. It's just not occurred, and it's time that it does. So I don't know exactly what the result would be, but I think that process is going to have to really have that robust engagement to get this down.
Thank you for your answer. No, absolutely. I agree. In the process of creating more inclusive measures of disability, we do need to think about ways to include the different ways in which individuals describe themselves. So, moving on, there's another question. The listener was curious about your thoughts on how this conversation fits into the international context. Um, so, as you know, internationally, there is heavy reliance on the international classification of functioning, which has led the functioning part to gain or to have a lot of traction. So, yeah, the listener is curious about your thoughts on this issue.
Yeah, that's another great question. And context obviously it really matters. I'm not, that's why I was saying at the end of the talk, I'm not against measures of functional limitation. And I personally would not be against using functional limitation to measure disability if the context, really demands that. I mean, if you're in an area of the world or country where it's obvious that that is how the disabled population defines itself, is through functional limitations. I mean, to me, that's the surveys within that country should be responsive to that and use that type of question. I mean, I personally think, disability identity in many ways is a privilege, a sign of privilege that we can actually say this is who we are, have pride about it, and define ourselves that way because we live in a society where, yes, we're marginalized. Yes, there's ableism, but we don't have direct threats. Not necessarily, not all the time. Shouldn't say all, we don't. But there are not always direct threats to our life because of identifying as being disabled. Or I know that there are places in the world where that's not the case, or where having a disability is going to automatically disqualify you from participation at all. So yeah, I would, and I personally think in our context in this country, we'll see what we do going forward. I wouldn't drop using the ACS-6. I think we've got to keep these measures of functional limitation, if nothing else, to have the historical trends over time. And so if we did that, we could still have some type of comparison with international standards. What I'm saying, though, is what we've heard loudly from the disability community, is we've got to quit pretending that in our context, in the US context, that this is the way that disabled people are defining themselves. And I think we also have to quit pretending that we're capturing and counting all disabled people when we use measure of functional limitations. Now that critique, to whoever asked this question, that critique would extend to international standards. And I've read some of the reports from other countries that are using some of the Washington Group measures, and there's some concern that those measures are missing disabled people who don't have functional limitations or who might not answer the question in such a way that it's being picked up. So I think practically, I wouldn't drop the questions, but I think we need to quit saying that this is capturing and counting all disabled people.
That's a great answer. It's an interesting discussion to reflect on how there are both differences and commonalities in drawbacks related to ways of measuring disability from the perspective of functional limitations, not only in the US context, but also internationally. So moving on, you already talked a little bit about this in your talk, but the listener wonders, besides having a broader umbrella of categories included in the questionnaires we use, can you tell us more about how we could better integrate the concepts of identity, for example, or accommodations that mitigate limitations into disability measurement?
Yeah, and Maggie Salinger at Brown, she's a MD at Brown, had a publication in one of the JAMA articles, I think it was JAMA Health Forum, about a year back, where she asked just a simple disability identity question: are you disabled? And I think that's going to, excuse me, have to be an important part of the equation, especially as we try to count disability among younger generations, where identity has been more prominent, disability identity has been. So yeah, going back to what I said earlier, I think this is what's going to be required up front, where we or whoever is developing these questions sits down with disabled people or talks with disabled people to figure out how do you describe yourself. So, but on the flip side, like I said, I mean, when she was still alive, I mean, you talk to my grandmother who was multiply disabled, and you would ask her if she's disabled, and she'd say, no, I'm not disabled. And then she would start naming her conditions, which could go on for the next 2 hours because she had a lot by that time, but she was never going to call herself disabled. So there's generational differences that I think, have to respect and are going to be really important as we do these measures. But yeah, I think the question is to the point that we cannot ignore that disability identity is a piece of this puzzle of how we measure going forward.
Thank you, Dr. Landis. Another comment or question we have in the chat asks, one of the reasons governments measure demographic characteristics on surveys is that they are very efficient shorthands, often quick, widely understood, and capture, even if imperfectly, a lot of bundled life experiences to some extent. Do you worry that a multi-pronged disability measure would be too long to be adopted for use in this way on a survey?
I mean, space is going to be an issue, although I will say on the flip side that I think these surveys dedicate space when they think something is important. And so maybe it's going to be a matter of them understanding that a quarter of the population is important and you can't just argue that it's a space issue. So space can be made, I would say. Yeah, I mean, that's going to be the whole process. And I mean, it's going to be a years-long process. Maybe national academies or someone would be interested in doing this, of fielding and testing some questions, because what I'm stating is kind of a long list of descriptors, and they're going to have to be narrowed down in such a way that you can fit them neatly within a survey. I mean, what I in my mind picture is that you'd have one type of open-ended question that would just simply say, all these descriptors: are you disabled, impaired, have these conditions? I mean, that could be used across surveys, and then those surveys that have more interest, like to me, the National Health Interview Survey or ACS, you could have some follow-up questions asking people to check all the specific disabilities or conditions, that they do have. And that's where you could have a longer list. So I think there'd be a way to have kind of one shortened question that does a better job of counting the fuller population, but then have some follow-up specific questions, maybe even inclusive of the functional limitation questions. So yeah, I agree space is an issue, but I also think the argument can be made that space is not as much of an issue when these federal agencies think the topic is important. And that's part of the problem, is disability has not been considered important up until now, to the extent that I'm arguing it should be.
For a great answer, no, absolutely important to take into account is considerations on field testing questions when it comes to disability metrics. Moving on, one of the listeners says there's a rich literature on the contentious history of the demographic measurement of race and ethnicity on the US Census and elsewhere. Are there any lessons the disability community can draw upon from these sources in pushing for change in disability measurement?
Yes, I think both with the rich and difficult history around measurement of race ethnicity. And I think also much can be learned from recent advocacy work to get the SOGI questions on the census, the sexual orientation, gender identity questions. And I know that advocacy efforts that are ongoing now within the disability community are doing so collaboratively with individuals who have been involved in advocacy, both around race ethnicity questions and the SOGI questions. So I know that's going on, and lessons are being learned and shared across marginalized groups of what's the best way forward. I think the other concern that I would share, I didn't get to it in the talk, is, some of these intersectionalities are going to be important to dig into, especially around the self-definitions of disability within communities. Somebody earlier had asked about international context. I think within our own country, context matters, and race, ethnicity matters, and age matters. And so that's what I was saying. We've got to have this robust dialogue with the disability community that is representative of the beautiful diversity that we have within the community across these intersectionalities. I do think also there's lessons to be learned, especially, among both the race, ethnicity, and the SOGI advocacy communities, about what does it take to convince agencies, legislators, policymakers that this matters, that you can't just ignore us anymore, that how you ask questions about us, how you do and don't count us is important. And I think we in the disability in the community are behind on this. We're not up to speed where these other communities are. So yeah, I think great point by the person asking the question. I think there's much to be learned. And I think those conversations are already ongoing, but we in the disability community are going to have to really try to catch up in order to push this forward.
Fantastic answer, highlighting the point of how intersectionality plays really a major role in conversations around disability measurement. What are your ideas on improving how we classify people with disabilities in healthcare now while working within current constraints? For example, the United States for data for interoperability, collecting disability status under health status assessment. Do you have any thoughts on this issue?
So yeah, I've got a ton of thoughts. Actually, a lot of my research is on the way intellectual and developmental disability is measured in the ICD-10, the International Classification of Diseases, that we use within the healthcare system here, as well as around the world. And specifically, I could give another talk on this, specifically that the CDC allows intellectual and developmental disabilities to be inaccurately listed as cause of death for people with these disabilities, which is something is called postmortem diagnostic overshadowing, which happens on half of the death certificates and obscures what we really know about death patterns for this population. But yeah, it's beyond just death certificates. Within any part of the medical system, it's the ICD-10 or bust. That's just the way that it's set up. And I don't know that to me, it's like the functional limitation questions. I almost think we'd be hurting our cause to say we've got to get rid of these. They're not going to go away. And I also think for historical data, we need these questions. And medical providers and government agencies need to know to some degree levels of functional limitation, and they need some type of way to classify certain diseases and conditions. But that doesn't preclude use of demographic as well. And so to me, a demographic, more holistic, robust, and inclusive question can be in addition to these other measures. And then, like I said, let's quit pretending. Let's quit pretending that functional limitations measure disability. Let's quit pretending that ICD codes actually are a good measure of disability, and let them serve the purposes they were intended for. To tell us how limited a person is, to tell us specific conditions, excuse me, that might actually be informing either a disability or impairment. But then add on a true disability measurement around disability as a demographic. So to me, this is a plus model. Let's not get rid of things, but let's shift how we use these measures, use them appropriately, and then have a robust, appropriate measure to accurately, inclusively, and equitably define and measure disability.
Thank you. I appreciate you putting forward that message to our audience. So looking at the time, we probably have time for one more question. So for other demographic characteristics, we don't focus as much on the duration of how long that characteristic has been relevant to that person. Um, if we move towards disability as a demographic, would this mean we should be less worried or more worried about this element um, in the context of additional questions for disability measurement?
It's a great question. I mean, a lot of times, and I think my own assumption is that we include a duration question is based upon the idea that we keep using functional limitations. And so I think that, and I did clarify this well in the talk, to me, the duration question really needs to be related to the functional limitations. I don't know, I'm going back and forth. On the flip side, I mean, knowing duration of disability matters in a lot of ways. I mean, I was born with both of my disabilities, and that's a really different experience to someone who acquired a visual disability or a health disability over time. So yeah, I think I guess they would, in my mind, it matters for both, for functional limitation and for disability status. Yeah, you're right. This is not something that we even consider for other demographic characteristics. Within the narrow frame, if we just define demographics as age, gender, race, ethnicity. Now, if we expand demographics, which is very often done to include things like education, then yeah, we do actually, not to the same degree, but we measure some type of duration or time period as far as time in school, things like that. So I think it's not unheard of. I think there are ways that we could do this by modeling other demographic characteristics if we expand to kind of consider that as a broad category. Yeah, but good point. These are good questions.
A fantastic answer. Well, thank you for the great discussion. So with that, I thank everyone for joining us today, and really thank you, Dr. Landis, for your time, your knowledge, and sharing about the work you have done around disability as a demographic, among other many important issues, trying to examine disability from a more sociological perspective. So thanks for being with us today. Thanks to the team behind the scenes running this and to our captioners and interpreters. We have another session coming up with Dr. Lydia Brown on May the 2nd. Please join us at the same time from 3:30 to 4:30. It's going to be a great talk, so tune in for that conversation. Thank you again, Dr. Landis, and thanks everyone. Take care and goodbye.